So I'm here at the 2018 ACEM annual scientific meeting with ACEM President Simon Judkins.
How are you going?
Who gave his President's Half Hour this morning. Sort of talking about, I guess, where the college is at and where you think you've kind of traversed over the past 12 months. And particularly some of those really important priority areas for you around social justice, gender equity. Wondering if you can share some of the thoughts that you shared this morning.
It's been an interesting 12 months and certainly an interesting conference because, as you know, along with this is our 35th sort of anniversary celebration of the college, and over the last 12 months talking to the previous presidents and founders, the college was really based on providing care for people in need. Emergency departments are a place where people come when they need help. And whether we've really thought about that or not, that really is, a lot of that is helping patients who can't get help anywhere else. We've realised, particularly in, for example, the mental health space, and as you know, we held our National Mental Health Summit looking at how we provide better care for patients with those needs. And that includes patients with drug and alcohol issues as well. So it's a broad spectrum of patients, but essentially, increasingly we're becoming a fairly strong advocacy body because we need to look after our communities, and our communities, when they need help, come to us. Whether we define it as an emergency, in the true definition of what we think an emergency is, it's an emergency for that patient. And if they can't access healthcare anywhere else, we need to advocate and work with them to provide better care. We would prefer that patients are able to access the care they need within their communities when they need it, rather than having to come to, a big and busy emergency department, which can, as we know, for some patients be, an intimidating place.
Someone made the comment this morning that your presidency is kind of redefined the role of the president in a sense. You've become a bit more open about political advocacy and about being outspoken on these issues.
Well, I think we have to, and a number of different reasons. I was encouraged, I think Tom Calma said it also in his foundation speech, that doctors have a responsibility in many ways to really ensure that our job is to help people. And if sadly, or some of our patients may not have the resources or may not have the networks or may not just have the know about where to go and what to do to get the help they need. And if we as doctors can help, I think we have a moral responsibility to do that. I think the other interesting thing is, for our specialty in particular, is we're very much linked into the public hospital system. And so we understand how the system works, we understand the positive things, the good things about the system, but we also understand where the deficiencies are. As a doctor working in a public hospital system, in many ways you don't have the capacity to be able to speak out about the system. So I think increasingly colleges and other medical bodies need to be prepared to do that work. And as I said, it's better for patients that we do it, it's better for our clinicians that we do it, and ultimately all we are trying to do is achieve better patient care.
You spoke about culture change within the college itself. It's been a big priority for you over the past 12 months and certainly for the college as well. Where are you at with this project?
It will be a continuous ongoing project. I can't say we're 10% of the way through, 20% of the way through. We are on I hate to use the word, I was going to say we're on a journey. That sounds really ridiculous, but we are. Medical culture is an interesting thing. We've heard so many stories about, we've trained doctors the same way for many, many years. We've run hospitals the same way for many, many years. And we've got to the point where we realise the way we've been doing things is not the right way. And changing the direction of not just one department, not just one hospital, but every big organisation that is somehow linked into the delivery of healthcare, medical training, that's a big journey. That's a big undertaking. But there's lots and lots of people who are stepping up and getting involved. But it really is, I think we are seeing some good gains. I think we're seeing some changes. I think we're realising there's a lot of people, more and more people out there realising that, there's a line in the sand. It's the behaviour you walk past. It's the bullying, it's the discrimination, it's the harassment, it's the unconscious bias, it's the discrimination. And whether that's discrimination between, medical colleagues, whether it's discrimination of our patients. It's all out there now. I'm encouraged that we're having the conversations. I think the more conversations we have, there'll be a bit of a Hawthorne effect, that people will start to change their behaviour. But we need to encourage people, I say encourage people, to also change their behaviour. And we need to be brave enough to have the conversations about what's acceptable and what's not. So I'm very encouraged that, I'm fascinated actually to see that I think most of the presentations I've seen in the last couple of days have touched on, the moments of kindness. They've touched on some discrimination, they've touched on wellness and well-being. So, this is a scientific conference, but, we also realise that a large part of what we do is not necessarily science. A large part of what we do is just being good doctors, and we sometimes need to learn how to be the best doctors, and I think that's, cultural competence, cultural safety, all of those things that actually make us better clinicians and better people.
So gender equity was identified as a big issue or a priority for the college last year.
Yep.
Doesn't look like anything much has changed as yet.
Yep.
Where are you up to?
So there's a couple of things. I think as a college we're doing, and if you look at the numbers, we've got 50%, we've got a pretty 50-50 mix at trainee level. So our registrars are 50% male, 50% female, actually more women than men. We've just had a recent spill of our what we call our CAP committees, our Council of Advocacy, Practice and Partnership, and we're very close to a 50-50 gender balance on those committees. Where we have got an obvious problem and is on our board, we've just put a paper out for consultation with all of our members, all of our FACEMs, to give us feedback about how we change that. So we are hoping, it's a slow process. If we could change it tomorrow, we would. But being a constitution and having rules and regulations, there are steps we have to go through. We hope that we can get through those steps, and we'll see some new faces and a different mix on our board very early next year. And then we'll make some other changes to try and encourage and break down some of the barriers. I think there are steps that we put in the way sometimes, and so. The other encouraging change for us is the formation of our Advancing Women in Emergency Medicine section, who are having their first meeting tonight. So there are some really good things happening, and I think we'll see some significant changes over the next 12 months.
Sounds like you're engaged in a real kind of a process of thinking about who you are as a college and where you're going.
Yeah.
You're drafting some core values.
Yeah.
Can you speak a little bit about that?
Again, the core values, part of our inclusion and diversity work, so out of the work the feedback we got from our expert advisory group based on our allegations of discrimination around some of our training processes, our discrimination, bullying and harassment survey, which looked at, and many colleges have done that work, but we really looked at things that were going to make a difference to really get people to think about who they are as a person, what links us all together, and part of the work that our Diversity and Inclusion Committee have done is develop some core values. Encouragingly, and the presentation was brilliant by a couple of our new fellows yesterday morning, talking about what those core values are. And so we've, again, put that out to members for feedback. We'll get their ideas, and hopefully towards the end of next year or early in 2019, we'll have a document that really binds not only the clinicians, but our trainers, but also all the staff at the college, who do some amazing work. But we just want to ensure that everybody really understands how we need to work as a team, and it's about respect and collaboration. But I think it really is something that we need to agree on.
You chaired a big session yesterday about the exams process as well, and
Yep.
Whether I think there was discrimination in the title.
Yeah.
Tell me a little bit about that.
Is the examination a discriminating?
Yes.
As
right.
in, is it really the thing that will give you, the tick as being a trainee who is ready to transition into being a consultant? And it's a complex and a tricky thing, and it's very hard. I think we all agreed that at the end of that, there's no perfect system that is going to dot all the I's and cross all the T's. And whatever we do in an examination process, it's not the same as what happens on the floor. And again, we looked at what we call our work-based assessments and other aspects of our assessment, and it is difficult to ensure that you get consistency across all those different departments of the training emergency physicians. The encouraging thing, though, in that session was that we had a lot of people in the room, and everybody, we all seemed to be heading in the same direction. We all agreed that there are limitations to what we can do, but ultimately we all agreed that we want to produce the best emergency physicians that we can possibly produce. And that included, again, issues around cultural biases and discrimination and educating, because we have to have doctors who can look after their communities, and our communities are diverse. And so, there was a comment that there will always be a bit of a lag time because your community may change a lot faster than the people who work in the hospital system or our trainees. So we need to ensure that we're on top of that, and we need to make sure that our clinicians have cultural awareness and they understand the needs of their communities. And that can be religious based, it can be culturally based, it can be gender based, but we need to understand that to ensure that our patients feel safe and respected, we need to understand what makes them feel safe and respected. There
was a big session this morning on mental health for doctors and burnout, and given by their eccentric character of Ken Milne, the bat dog.
Yeah, bat dog.
What are your thoughts on, this is a big discussion that's happening in Australia at the moment, not just within your college, but more broadly?
I think that the conversation is very interesting, and I think, and obviously it's a huge issue. It's the thing that most people agree on is that it's the system, that we work in that really. Remember Daniel Fadovich gave a talk at the Mental Health Summit, and he talked about the team of emergency, the team that works in the ED, and the unseen member of the team is the system, and the system sometimes prevents us from delivering the care that we want to deliver, and the system sometimes stops us from getting a patient admitted to the ward when they are ready to go to the ward. And I think the system plays a huge part in the way that we feel we manage our patients, we manage our own, our well-being. And I remember talking recently to a young trainee about, her trying to juggle the demands of, the family and the examination and work, and that feeling of guilt that she was leaving an incredibly busy emergency department to go home and spend time with her family, but knowing that she was leaving behind her colleagues who were drowning in the work that was presenting to them. And, that's just an awful thing to think, that we have a system where you have people who are incredibly dedicated to the work they do, feel guilty about not being able to do all the work. And, doctors are a little bit obsessive sometimes. We're perfectionists. We want to do a good job. And if you put up barriers in front of people who just want to do a good job and prevent them from being the best they can be, then it's going to lead to an incredible amount of stress and burnout. We talk about resilience. We need to be more resilient. No, we don't need to be more resilient. We need to actually provide people with the right resources to be able to be, great doctors. And I think that's something that we really need to look at. Now, politicians and the people who can provide that, that environment really need to pay more attention.
Well, it's an interesting question about systemic issues and resources. I don't know if you've seen about the New Northern Beaches Hospital in Sydney, and I'm sure you've seen it in the paper, Do you have any thoughts on, this whole privately run public hospitals? And
My views are, I think most people know, I think medicine isn't for profit making. I think we've got a fantastic healthcare system, but if we're running hospitals in order to for an organisation to possibly maximise their profit or reduce their spending because they're concerned about that, I think that is a significant problem. I think our public hospital system is provides incredible care, and we look at comparing that to any other health system around the world. We tick a lot of boxes. And I think the people who are working in that hospital should rightly be frustrated that, they expected better. And again, they want to provide great care for patients. And if they're working in a system that doesn't allow them to do that, they should rightfully be angry.
And what can we do about it, as an advocacy organisation, or yourself, I should say?
I think, again, this is a difficult thing because we have spoken about this for a long time. That one of the problems that we have is that politicians change, health ministers change, and then we're telling the same story to somebody else over and over again. I think a lot of the decisions around healthcare need to be, as much as they can, separated away from the rolling cycle of politicians and health ministers. I think we need to have well-informed, highly educated. We need people who run health systems to be able to make long-term plans which are not necessarily linked to election cycles, for example. And I think people need to listen to clinicians. We need to listen to our patients. And if patients are telling us that they're having bad experience, if our mental health patients, for example, are saying, I don't want to go to the hospital because it makes my anxiety worse, and I have nowhere else to go to get my health care, that's a huge red flag. That's a big alarm. And we should be providing, we should be solving those problems. I think we need to move away from, data. The stats are really powerful, they're really helpful, but we need to attach patient stories and clinician stories because, if we're investing years of education, training, to get clinicians to a point where they become specialists, and then they work in a system that is then going to burn them out, and so they then don't want to work in that system after 5 or 10 years, we're not doing things right. We've got to change that. We should be investing in these people, and again, ensuring that we provide them the resources to do the best job that they can possibly do. And then we would have a much more effective and efficient healthcare system with much better outcomes for patients.
You've got 12 months left in your tenure. What are your priorities? What are you hoping to smash out of the park before you ride off into the sunset?
I don't know. I think this will be just an ongoing piece of work. Really, the thing that I want to really do, and as I said this morning, was I want to every clinician who works in the system realise they actually do have the capacity and the ability. Part of their job is to advocate for the system they work in. And if we can get all doctors to actually just, really... I know it's very easy to become disengaged when it's hard, but also it's not going to become better if we're not all engaged and we don't have that common goal of advocating for our system to ensure that it's sustainable and to ensure that it can deliver the best care, to ensure that it looks after patients and staff. So if I can get as many people as I can on that sort of trajectory, onto that bandwagon, and we can generate some enthusiastic new leaders, then I think I will have done my job.
A formidable task.
It'll be fine.
Especially heading into an election year.
Yeah.
Thank you, Simon. All the best.
Worries.